to primary care. And this is done by helping practices implement oral health risk assessments, oral health evaluations, fluoride varnish application, dental education to parents, referrals to a dentist, and this is done during the well-child visit. From the First Tooth, staff offers technical assistance to practices, including training for clinical staff, workflow development, and EHR integration. So for some updates from the First Tooth, we have recently started to offer live Zoom trainings to practices. Hopefully not everyone's too zoomed out, because I think that this training is very exciting. It's based on the National Smiles for Life curriculum and includes a live demonstration of fluoride varnish application. We're also excited to be releasing the From the First Tooth toolkit in June. And this is a great resource for orienting new staff to the From the First Tooth program. The toolkit includes billing information, oral health metrics to measure success within a practice, and a list of dental referrals. And so I believe in the follow-up to this talk, we can send out a link to the tool to request a toolkit. And this also includes an option for training, to request training for a practice. So I look forward to working with you to support oral health within your practice. And thank you.
Thank you. That was great. So it is my honor to introduce Dr. Hidu, who grew up in Hampton, Maine, went to the University of Maine in Orono, and graduated in 2017 with the Tufts Maine Track program. She developed a passion for primary care while participating in the longitudinal integrated curriculum, clerkship during her third year at Midcoast Hospital. Dr. Hidu is graduating from the MMC Internal Medicine Pediatrics Residency Program this summer, and was the MedPeds Chief Resident, and she will become the Pediatric Chief Resident in July for next year. Dr. Hidu is hoping to go into a combined internal medicine pediatric primary care practice in Southern Maine. And personally, she likes to spend time outdoors, particularly on or near the ocean, with her fiance, Zach, and her dog, Tilly. So we are so happy that you're here. This is a fantastic talk that integrates oral health and disparities. And I also just want to remind people that for quite some time, the AAP included oral health as part of the agenda for children, which is really the foundational guidance that the Academy uses as they do their work. And so this is definitely an important topic, and has been for some time. And so I think this talk is an excellent take on where we still have to go with oral health in so many ways. And so we're just super psyched that you're able to do this, Erica. And I know this isn't easy as a resident, but the first time I heard this, it was so fantastic. We just couldn't let an opportunity go by to have you here tonight.
Thank you very much, Jen. I'm happy to be here. Thank you guys for inviting me. I'm going to share my screen. So it'll just take me a second here. All right, so you can all see my first slide there.
Yep, looks good.
Awesome, great. So as Dr. Jewell said, I'm Erica Hidu. I'm a fourth-year MedPeds resident, and today I'm going to talk to you about disparities in dental health. All right. To Dr. Hoffman's question, yes, I will very briefly talk about CLINs, fluoride, and dental assistants in pediatrics practices, but really the bulk of this talk is to help identify disparities in dental health care, and to help with the anticipatory guidance that we can give patients and their families around dental health care. I also am going to briefly talk about the current inadequate coverage of adults when it comes to dental health care and why this impacts pediatric dental care. And then I'm also going to talk about a few resources that we have here in Maine and potential future directions for pediatric dental care. I have no financial disclosures. I would like to point out, however, I am not a dentist of any variety. I do not have any special training. I am just a MedPeds resident who was very uncomfortable with dental care, so wanted to learn more about it. And as with all good research journeys, this one was inspired by a couple of cases I saw. The first one was a 5-year-old female who I met in the pediatric clinic here at Maine Med, who presented with some tooth pain while she was eating ice cream. She was a child of Rwandan parents. They'd been here for about 6 years and she'd never seen a dentist before. The second patient I saw was in the MedPeds clinic. She was a 26-year-old who was born in the US, grew up in Maine, and she was coming to me after a hospital stay for which she had bacteremia and an empyema, and all her teeth had to be removed because she had such poor dentition. And one of her big questions for me was, how do I get dentures through MaineCare? So these were the cases that drove me. I certainly did not feel like I knew enough about dental care to try and help these people at first. And so the first thing that I wanted to kind of review and learn more about was the burden of dental disease. Now, just let this sink in. Dental caries are the most common chronic disease of childhood. This kind of struck me because as a pediatrics resident, I'm training in the management of chronic pediatric diseases, but this is just not one that I feel very comfortable with. Another striking piece of data is in children less than a year of age, 88% of them had regular doctor appointments, but less than 4% had regular dentist appointments, despite the fact we know full well children develop teeth before a year of age. Growing up in Maine, I always heard that dental care was a problem here, and that's certainly borne out in the numbers as well. According to a parent survey in 2015, 16% of children did not receive any preventative dental care. And knowing what I know, that's probably a little low, to be honest. I'm sure that number is in reality much higher. According to claims data in 2017, 42% of children on MaineCare had any sort of dental visit compared to 67% of children with commercial insurance. And by the 3rd grade, 4 in 10 Mainers had caries, which is just a statistic that kind of breaks my heart a little bit. Now, dental disease is associated with lots of other negative effects, both in childhood and as children grow older. So this study was published in the Journal of American Dental Association in 2017 and looked at about 1,000 children. And they looked at them both in their like early teenage years and then as they grew into young adults, and evaluated whether they had identified as having deferred dental care, and then looked at a few measures of cardiometabolic disease. What they found was that children who had deferred dental care in their teenage years, so 12 to 19, then when they were in their 20s and 30s, had they also had a high BMI and were also associated with higher levels of blood pressure and actual diagnoses of hypertension. This is all associative data, not causative, all correlative, but still trying to get a bigger idea of what's going on here. Poor dental care is also associated with missed school and poor school performance. This study was looking at about 2,000 children in North Carolina in 2011. And what they found was that children whose families rated their dental care as being good, fair, or poor were 3 times as likely to miss school for dental pain compared to those who rated their dental care as being very good or excellent. And more importantly, the absences that were related to dental pain were almost twice as likely to result in poor performance compared to those absences that were related to preventative care. And these negative effects are not spread evenly across children. In Maine, we see a gap in older children between those with MaineCare and then those with commercial insurance. And we also see a pretty significant drop off here once children get older. And this is particularly problematic because 14 states, including the state of Maine, have no preventative coverage for adults on public health insurance. So MaineCare only covers emergency care. I actually took a look through the MaineCare reimbursement manual, which as MaineCare covers adults who are 21 plus, which could include some patients still being seen by pediatricians. And MaineCare only covers extractions, that's it. And either for two reasons. One, if you had a traumatic injury, or two, if you had teeth that were so severely decayed that they posed a serious threat during surgery or radiation therapy. And if you were lucky enough to meet the really high bar of getting medically necessary dentures, you better hold on to them because you only get one pair every 5 years. So we've identified that poor dental health care is a problem, but I still feel like I don't have enough time to talk to every single one of my patients as in depth as I'd like to about dental care. So who do we target? There are multiple risk assessment tools out there, including one from AAP, which is represented on the right. But parents have a lot of forms to fill out, so I'm going to distill down kind of the risks and protective factors for you. So in general, the risk factors for dental disease include the presence of maternal dental disease, bottle or sippy cup use with a liquid other than water in children over 12 months of age, frequent snacking, children with special health care needs, and children who are Medicaid eligible. Protective factors include children who have an established dental home, children who have some sort of fluoride exposure, whether in their water through supplementation or through varnishes in the last 6 months, and children who brush their teeth twice a day. One group that's not identified or mentioned even in these risk assessment tools are folks of racial and ethnic minorities. And as we are well aware, folks of racial and ethnic minorities are at a disadvantage across the entire healthcare system, and dental care is no different. This is data from the CDC, and it found that Black and Hispanic children were more likely than white children to have untreated caries, whether that was in the preschool age, the school age, or the teenage years. They were also less likely to have access to preventative dental care like dental sealants compared to white children of similar ages. This study was published in the Journal of Public Health Dentistry back in last year, and it looked at about 1,000 children in Northeast Ohio and found that children who identified as being Black were more likely to have been to the hospital or the emergency department for a dental related issue in the previous year, were more likely to have a lower oral health quality of life score, and were more likely to have poor access to food. This is a big chart. The main thing I want you to take away from this is that all of the p-values are significant, which means that if a child identified or a child's family identified as being Black, they had a higher rate of dental disease in both their baby teeth and their permanent teeth compared to those who identified as being not Black. I also want to mention a lot of the data that I report in this presentation are all cross-sectional studies that due to their nature have big tables like this. I will make sure to summarize the findings for you, but if you want to see something more in depth, just let me know and we can review it at the end. So I wanted to tailor this talk a little bit to Maine and more specifically to the population I work with here in Portland, where the vast majority of our non-white population are immigrants or children of recently arrived immigrants. So the next few papers look specifically at refugees and asylees. This was a study that was done in Providence, Rhode Island at Hasbro Children's Hospital. And it's probably not surprising to anyone here, but not all immigrant populations are the same. And there are significant variabilities in dental practices based off of country of origin. So the folks at Hasbro separated out their refugee population into either from African countries, which included folks from the DRC, Somalia, Burundi, and Rwanda, similar populations that we see here in Portland, and an Asian group, which was a little bit more diverse. They included children from Syria, Iran, Iraq, but also Myanmar, Thailand, and Tibet. What they found were that children who were grouped in coming from an Asian country of origin had a higher risk of caries compared to the African cohort. They also required more emergent intervention on the caries present. The one thing I will point out about this, though, is that the Asian patients did tend to be a little bit older, which may have confounded the results a little bit. However, we still see these differences in other studies as well. This study was published in Pediatrics in 2004 and looked at not only refugees in different regions of origin, but also compared them to US children. And it looked at participants that were going through the Massachusetts Refugee Health Program. They grouped them either from being from Africa, mostly Somalia, Liberia, and Sudan, and they predominantly identified as being Black, and then compared them to an Eastern European cohort who were from Bosnia and identified predominantly as being white. And they looked at both their history of caries, and then also they evaluated them for the presence of caries after arrival here. What they found was that there were, again, significant differences based off of where you came from. European refugees were more likely to have had been to the dentist, and they were more likely to have used a toothbrush in their home country compared to the African group. However, despite these habits, there was actually a heavier burden of disease in the Eastern European group. They were more likely to have dental disease in the past, have current untreated dental caries that needed urgent treatment, and were more likely to have more than 10 dental caries on exam, compared to the African group that had a lot less burden of disease. There's some theory that there is something intrinsic to the region of origin, whether that be decreased levels of refined sugars, lower likelihood of cariogenic bacteria, or different cultural practices around dental care that would not have been identified as being part of the European-centric definitions used in the study. Now, this is what I found particularly interesting. When they compared these refugees to US patients, what they found was that the white refugees were more likely to have had caries than US children, but even more likely to have caries, or they were even more likely to have caries than white children after arrival. However, African refugees were less likely to have had caries compared to Black children before arrival, but after they arrive, they start looking a lot more like Black US children in terms of having higher rates of dental caries. The next group I looked into were children of low income families. And again, this is the CDC data, and they looked and saw in every age group, those children who were below the federal poverty level were more likely to have caries compared to their aged matched peers that were above the federal poverty level. They were also less likely to have access to dental sealants than those above the federal poverty level. And this is particularly impactful later in life because whether being from a low-income family, being identified as Black or Hispanic, all of these groups in adulthood are less likely to have their full set of teeth. So chances are their high rates of caries and their low access to preventative care result in higher tooth loss in adulthood. The final group I wanted to review were children with special healthcare needs. Just like immigrants, these are a very heterogeneous group, so I wanted to highlight a few key diagnoses. This paper was published in BMC Oral Health in 2013 and looked at a group of children in Head Start programs in Washington State. They looked at a variety of factors that they thought would be associated with dental disease. And what they found is probably not surprising, which is that developmental delay was associated with a higher rate of dental disease, as was children with communication difficulties, children of parents with lower educational levels, and children who did not have a dental home or did not have fluoridated water. The children who had those two things were less likely to have dental disease. The same year, this study was published in the Journal of International Pediatric Dentistry and looked at children with autism spectrum disorder in Egypt. And what they found was that children who had autism spectrum disorder were less likely to have seen a dentist in the previous year, were more likely to have difficulty finding a dentist, and were also more likely to brush their teeth less, have more difficulty brushing their teeth, and require more supervision to brush their teeth. They also found that children with autism spectrum disorder tended to prefer sweet snacks over fruit. I'm sure none of this is like groundbreaking information to any of you who work with children with autism spectrum disorder, but it's nice to see actually that that's present in the data as well. Now, not all children with special healthcare needs are created equal. This study that was done in Charlotte and published in 2019 in Pediatric Dentistry looked at a few different diagnoses and compared them both to each other and to a healthy cohort. And what they found was that children with special healthcare needs that had one of these diagnoses were more likely to have public insurance, were more likely to prefer sugary drinks or snacks, more likely to be on a medication that induced xerostomia or dry mouth, were more likely to have difficulty with oral hygiene, have a liquid or pureed diet, or to be G-tube dependent. However, when they broke down these different diagnoses and looked at the actual dental caries they had present at the time of the study, only one group was significantly different, and that was children with congenital heart disease. This study done in Canada actually looked at a variety of children with many different diagnoses of consistent with congenital heart disease, and found that almost 50% of them had severe dental disease on exam. Some of the reasons that they postulated may be the reason why congenital heart disease, children with congenital heart disease are at higher risk for dental caries include poor dental hygiene, cariogenic diets, chronic administration of sugar-based liquid medications, and then also parental anxieties about putting their kids in stressful situations like going to the dentist. So that was a lot to review, but just to go over it, the main points I want you to take away from this are children of racial and ethnic minorities and of low-income families are more likely to have dental disease, less likely to have sealants, and more likely to lose their teeth. Immigrants are not all created equal, and actually African immigrants who may have less interaction with dental health actually tend to have a lower burden disease prior to arrival than Eastern or Asian cohorts. And children with special healthcare needs are not all created equal. There is some evidence to support congenital heart disease, autism spectrum disorder, and children with developmental delay are more likely to have a higher burden of disease. So now that we have identified our high-risk population, the next step is to move on to the pillar of primary care, which is anticipatory guidance. As many of you guys know, Bright Futures is a group within AAP that reviews and recommends guidelines for preventative and well care. The advice I'm going to review comes from 2016. I'm not only going to go through it in detail, but I'm also going to lead you through some of the papers and some of the evidence behind it. So for kids less than a year of age, Bright Futures recommends that parents focus on their own dental hygiene, avoid bottle propping, use a washcloth to clean the gums, and then they also recommend not sharing utensils or pacifiers. This comes from the idea that these utensils could act like fomites, transmitting cariogenic bacteria like strep mutans. So this was something that I found pretty interesting, so I decided to look at the data behind it. This was one study that was published in 2011 and looked at Japanese 3-year-olds and their caregivers. So in Japan, I was pretty jealous of this. In Japan, all 3-year-olds have their dental care evaluated by the municipality. And they asked the parents whether or not they actively avoided sharing utensils and pacifiers, and then looked at them, the children, in exam rooms and looked for the presence of caries. Well, the initial evaluation showed that those parents who said they actively avoided sharing utensils, their children were less likely to have dental disease. When they controlled for things like age and sex, dietary factors, toothbrushing habits, and socioeconomic status, those differences went away, which implied that these other factors are probably more likely causing that difference. However, I think personally, I still wouldn't put those things in my mouth just because it seems gross to me a little bit. So from ages 1 to 4, they recommend discouraging thumb sucking and avoiding juice and sugary beverages. So this made me want to look at dietary advice. This popped up on multiple other studies as a kind of known risk factor for dental disease. Seems to make a lot of sense. So I wanted to see about the data behind it. Cochrane reviews do actually have a meta-analysis that answers this very question. This was published back in 2019, and they found 3 studies, 2 out of Brazil, 1 out of the UK. There's a lot of Brazilian pediatric dentistry data out there, by the way. I don't know what they're doing down there, but that's a big center for pediatric dentistry research. And these studies actually looked at women who were either pregnant or had children less than a year of age, who were given specific advice around encouraging breastfeeding, avoiding sugar, and advising against using bottles around sleep times. And they followed these children up until 6 years of age. And please excuse the quality of this slide. This is exactly how it looks like in the paper. But what they found is that the women who received the specific advice around dietary advice to help decrease dental caries, they had a relative risk of 0.85, which was just fairly significant compared to those who did not receive advice. So it seems like giving parents advice about these things does help a little bit. When I gave in children who are 5 to 10 years of age, they again emphasize avoiding sugary drinks, and then they also recommend using mouth guards with sports. When I gave this presentation in March, one person specifically asked me about seltzer water. And what I found was that there isn't a lot of data around seltzer water specifically, except for one study in 2007 that showed that it's about as erosive to your teeth as pure orange juice, which does erode your teeth. And so you should caution people, and whether it's parents for themselves or for their children, that they shouldn't be bathing their teeth in seltzer water all day. However, when compared to soda, it's significantly better. And as someone who is like very fond of my seltzer water, this made me a little sad, and I think I'm gonna start switching back to still water a little bit. But the absence of sugar in seltzer water, it certainly does have a benefit over, for example, sodas. For the teenage crowd, there is actually an adolescent transition toolkit section on pediatric dentistry, but you also want to make sure that you talk to them about substance use, particularly tobacco and meth, and eating disorders. Anything with purging is going to cause enamel erosion. Piercings can also cause trouble with your teeth, both because of infections, but also because they can fracture teeth as well. You may have noticed that I didn't talk about toothbrushing yet, and I figured it warranted its own slide. This was something I was interested in because I had heard cautions about giving young children fluoride toothpaste, but Bright Futures actually recommends that you give a fluoride-containing toothpaste to all children. The difference is in the amount. So twice per day, you should put, for children who are less than 3 years of age, just a small smear or like rice grain size of toothpaste on a toothbrush and brush their teeth. You don't have them spit, you don't have them rinse. It's basically like putting on a little bit of a varnish every day. The idea is that with this small amount of toothpaste, they won't be ingesting as much of it. so they won't get those like higher fluoride levels. Once children are over 3 years of age, you can give them a pea-sized amount of toothpaste. And the recommendations are that if they've got extra in their mouth, they can spit it out. But again, they don't need to actually rinse it out. The other thing I'd like to point out is supervision. So until a child can tie their own shoes, they really should have supervision while brushing their teeth. And you should start recommending that parents talk to their children about flossing, really starting at age 5. So Bright Future guidelines can be used for all children, but there are specific guidelines around those with special healthcare needs. These ones are put out by the American Academy of Pediatric Dentistry, and they recommend that these children have a dental home that has flexible appointments, that their primary doctors refer them as early as possible, that they be aware of the patient's sensory issues and triggers and develop an individualized preventative plan, that everyone encourage a low-carb diet. And I thought this last one in particularly was important, reviewing medication lists to make sure that you're decreasing medications that can cause dry mouth. So things like Benadryl, for example. Also decreasing when possible the liquid medications that may contain sugar. So if a child is able to go to pills, that might be preferred. But we can't just talk about getting to a dentist. Despite the fact that we are getting better in terms of talking about it, claims data shows we are no better at actually getting children to the dentist compared to about 20 years ago. So what can we do about it? This, Dr. Hoffman, is my slide on fluoride and sealants. I am not going to go into depth with these two because they could each be an hour-long presentation on their own, but I wanted to briefly review them because they are both important and evidence-based. So fluoride, specifically fluoride varnish, can be performed really by anybody, but in particular, primary care doctors. It can be applied every 3 to 6 months, depending on risk factors, applied to all teeth as soon as you get your first eruption, hence from the first tooth. And the best method to go about it is to actually dry the teeth with gauze and then apply the varnish, and actually recommend that while the child can eat or drink soft foods, they not actually brush their teeth that evening. Sealants can be performed by dentists or their associates. They're applied to the molars usually at around 6 years of age when those first molars erupt. They last about 2 to 4 years before they have to be replaced, and they are recommended for all children. But because not everyone has access to these services, there have been multiple public health initiatives that have gone to address dental disease. One of those is fluoridated water. It was actually added to the water in Grand Rapids, Michigan in 1945. And as of 2016, about 73% of the US population has access to fluoridated water. Maine ranks about 23rd in the US with 79% of our population having access to it. That doesn't necessarily reflect the folks who use it. For example, if you have a town that has fluoridated water, but you use a well, you're not going to get the fluoridated water. Interestingly, the state with the most access is Kentucky at 99.8%, and New Jersey comes in at last place with about 16.2%. School sealant programs are another kind of federally funded program, or funded both at federal and state levels, and these provide sealants in the school setting. And one thing that I thought was really important to emphasize about school sealant programs are not only do sealants work to prevent dental disease, but they actually work to help target those at higher risk for dental disparities, specifically Mexican American population and lower income children in the study that was done kind of across the US. But sometimes you need more services than just this. So I'm going to go into some of the resources that we have access to here in Maine. The first one is the Partnership for Children's Oral Health. They are a group that does a lot of things across the state in order to help promote the oral health of children. One thing I want to highlight is actually this website linked down here. where you can go, this isn't just for Portland, across the entire state, you can zoom in and find all of the dental clinics that actually will accept children, and it gives you all of the information. You know, what kind of insurance do they take? What do they do? What are their hours? What are their contact information? So this is super helpful for anybody across Maine to use. From the first tooth, as we heard about from the beginning, thank you, Olivia, for giving us more information about that. They are one of the programs under Partnership for Children's Oral Health, and I'll just leave it at that. But they help primary care offices improve oral health, not just in the state of Maine, but actually across all of New England. Another tool that we have is this AAP primer. I put the link on the bottom of my screen here, and this has a variety of tools for pediatricians, whether you want to learn more about them, whether you want to learn how to get paid to do these things. This is all actually under this prevention primer. In Southern Maine, in the Portland area, we have the Maine Access Immigrant Network that was actually founded in 2002 by the Somali community. And one of the things that they do is help connect recently arrived immigrants with health and dental services. They hold workshops, they have events, and they actually have community health workers that help get people access to care. And again, in Southern Maine, there is this group that has actually a mobile clinic. It's called Mainly Teeth, and they not only provide services to pediatric patients, but actually have additional training and experience with kids who have special healthcare needs. So they provide a variety of services, including referrals if more intensive evaluation is necessary. So in terms of future directions, we, particularly in the state of Maine, sorry, this should say LD, I thought I corrected that. LD 1501 is an act to improve oral health and access to dental care for Maine children. And that is actually in the Committee for Health and Human Services. And this is actually looking to establish an oral health coordinator and put in specific money to help analyze data across the state to help inform performance, and also expands funding for school-based programs across the state for both fluoride application and sealants. Now, this is not a huge part of my presentation, but I did want to mention the virtual dental home. And this is the idea of having dental hygienists actually embedded within the pediatric office. They can do an evaluation and then do an e-consult with dentists. And there's actually a trial going on right now with Head Start programs, but this is potentially something that we could see expand in the coming years. So as I'm kind of wrapping up here, the main learning points I want you to walk away from are that there are significant disparities in dental health. These occur in children who are of racial and ethnic minorities. Although immigrant groups are definitely not heterogeneous, some are more protected prior to arrival than others. There are disparities in children who come from low-income families and children who have special health care needs, including those who have autism spectrum disorder, developmental delay, and congenital heart disease. Anticipatory guidance does help, particularly talking to parents about dietary changes and decreasing bottle popping. Maybe sharing utensils is not a great thing, and you should definitely brush your teeth twice a day. That was a study I didn't review in depth today, but I did find one that was like, yeah, it's probably best to brush twice a day. There are multiple resources, whether through the AAP or the Partnership for Children's Oral Health. And the big thing that I want to leave you with is to remind you that as of right now, there are bills out there that are looking to change it, but as of right now, there is no coverage for preventative dental care for adults. So we as pediatricians, it is our job to set up our patients well in their childhood years in order to prevent them from losing their teeth and needing dentures as 26-year-olds. Which brings me back to our cases. For our 5-year-old patient, we did see some caries on her exam, so we applied some fluoride to those and then referred her to a school-based dental clinic. And then for our 26-year-old, I still don't think I've been able to get her access to dentures, which is just really, again, sad. I want to again thank everyone who helped me with this and invited me out here. I am just realizing there's some chat. There are some things in the chat, maybe. Nope.
I wanted to say something. I don't know. Can you hear me?
Yep.
Let's see if I can put my video on. I don't know. Anyway, I'm on my phone. I'm Karen Seidler. I'm a psychiatric nurse practitioner, and everything you said is just so on point. You know, what I see in terms of access to dental care in children, and particularly I work with developmental disabilities, and I have my own son is special needs, and just the lack of dental, like, so my son has oral defensiveness and he doesn't like to brush his teeth. And so literally for the first 18 years of his life, I brushed his teeth and I flossed them because that's how much of a nut I am. But then, you know, you get tired, you know, he's 25 now. But I also wanted to say the whole thing. So working with adults, when I moved here to Maine, I don't know what the dental care was like for people on Medicaid in New York State, but my adult psych patients, you know, would get their teeth pulled when they were bad enough, but they had to be bad enough, like you said. And what I found out from my dentist, because I was, you know, complaining about the dental care for people on Medicaid, he says that if you pull the bottom teeth actually support the upper teeth. So the tooth directly above the bottom tooth that's pulled will start to loosen and will eventually start to fall out. So you end up losing both teeth. And so it's just so awful. I do know, I did actually talk to, there's some representative in Saco, because they're trying to improve the whatchamacallit, the legislation around it. And I also brought this point up that with adults, it's, you lose two for one. So anyway, so thank you so much, because it's really appalling. It's horrible. And then, we know in animals, in vets, are like, get your animal's teeth cleaned because of the level of disease that happens because of it. So, and then of course there's the whole dietary thing, which is people get only so much, in food stamps. So what are they left to eat? But the stuff that can help sort of fill them up, and that's not healthy. So.
Absolutely. And thank you for sharing. And according to this graph in 2019, New York had pretty extensive preventative care coverage. So
Thank you.
We're kind of the standout, which I know unfortunately sometimes happens, is Maine can look somewhat more like the South than the rest of New England. All right. Dr. Hoffman, I think you raised your hand as well.
Yes, Michael Hoffman here. What can we do to convince dentists to take the Maine care patients? That has always been an issue here in rural Maine. The dentists I go to either don't take Maine care patients, or they might take one a month, and they have all kinds of excuses. The Maine care patients don't show up, they don't get paid enough.
Yeah, and I have definitely gotten into my fair share of arguments at weddings with dentists where I've asked them that very same question. I think actually one of the adult bills, if I can remember correctly, and Dee, feel free to correct me if I'm wrong, but one of the bills that's currently in front of the Health and Human Services Committee is to help put funding towards decreasing those main care caps with some of the dental practices. So I think there is legislation out there that's currently working to address that. But as what we can do besides speaking on behalf of some of these laws, unfortunately, I don't think arm twisting is going to really be super helpful.
I will say there's the dental clinic that's right down the hill on Park Street that has been quite cooperative. I've worked with them to try to get them to see patients who are starting chemotherapy, and they're willing to come up to the hospital. So I guess I'm saying some dentists go out of their comfort zone sometimes.
Yes, thank you very much of mentioning them. Yeah, community dental, they not only have been awesome about coming to where our patients are at, but they also specifically work with immigrant populations on a sliding scale, and also have school-based dental clinics in at least the one I've been to, the one at Deering, and they have them at a few other schools as well, where kids literally, they're in study hall and they get a pass to go to the dentist, which is kind of awesome. And I'm hopeful that with, LD 1501, maybe we'll have a little bit more kind of moving towards that in some ways. Norma Desjardins. Oh, you're on mute.
Hi. Thank you so much, Dr. Hidu, for this really great presentation. I just want to mention that I am a dentist, and the only way that I could really afford to see main care patients as a dentist was to create a nonprofit organization called the St. Apollonia Dental Clinic up here in Presque Isle, Maine, in Aroostook County, because I saw with 25 years in private practice that it was going to be very difficult to try to help this population and remain as a privately practicing practitioner with my own business to run, my own bills to pay, my own employees to pay, and everything that comes with that. And so I created a nonprofit. And that means that I rely on very generous organizations such as PCOH, such as donors, other foundations, lots of great private foundations out there that help us subsidize, what we do so that we can continue to pay the bills. And so it's a very tough situation. Every time we do dentistry, we're like operating a little mini operating room. We have lots of costs. We have lots of equipment. And so I know that's not really the purpose of this discussion, and that's not really why I'm here, because I'm here because I have a true interest in public health, as you all do. And I do feel that prevention is the #1 way and the most cost-effective way to treat the disease before it even happens. And so the different programs that we're talking about, how can we ensure that we are providing the education to the parents and the child so that the parent understands the vertical transmission of disease, so that the child is not having soda in the cup, so that, families get it when they hear the message that water is indeed cheaper than soda. You can get fluoridated water from the tap. And, so there's a lot to it. And I think what needs to happen, and what I'm really trying to work on, and what I really appreciate being in on this conversation, is that I want the dentist to continue the conversation with you guys and with the pediatricians, so that we can address the issue and not, put it aside. And as far as the patient who's 26 years old and needs dentures, if she truly needs dentures, our hands are tied even as dentists to try to get dentures for this patient. It's very expensive to have a set of dentures made. Very, very expensive. And the main care reimbursement for it barely covers the lab rate. So if the dentist is paying the lab to help create the dentures, there is nothing left to pay the dentist or the denturist for the time that they spend with that patient. And I have done a lot of dentures for patients over the years. It takes a lot of time with patients.
So is the problem the reimbursement from main care?
Yes, and we're finally making some progress. That is the problem.
Okay.
The reimbursement rate on the dollar is anywhere from 30 to 45 cents. What we charge. And so that's a lot of overhead that you got to cover that you're not getting reimbursed for.
And how much of your practice is pediatrics versus adults?
At St. Apollonia Dental Clinic, we have 75% is, well, no, wait a minute. 75% is main care. We are geared towards 0 to 21 years old. During the pandemic, we took on adults with urgent care needs. And so we're right about 90 to 92% children right now and about 8 to 10% adults. Of those children, 0 to 21 years old, 75% have main care.
That's fantastic. I think you're doing a great service for
Well,
kids
it's
in Maine.
fantastic, but it's also a little bit crazy because it's
I agree.
a lot of hard work and a lot of grant writing and that sort of thing.
Yes. Yep.
But if we weren't here, I'm not sure what would happen.
Right. Right. It's I think I can speak for all the pediatricians here that what you describe is very humbling, and we don't see, I mean, to see somebody who notices the problem and then goes so far above and beyond to develop and staff and fund a not-for-profit, I agree, is tragically sad and heroic on your part.
Well, and I don't do it for any kudos at all. There's
easier ways to get kudos than that, for sure. We get that, but it's still, it's pretty amazing.
I'm not a shining star. Most days I feel very dull, but I also have kind of thought, Dr. Hoffman, about the whole issue of if every dentist did a little bit, maybe none would have to go broke. And apparently a few years ago, there was a dentist, Jeff Dow, who tried that. He said, what about if we just all take 10? And I'm trying to do a little research to find out a little more about how far that went. But the other thing is that if the privately practicing dentists can't take them or won't take them, then we have to really support the FQHCs, the nonprofit clinics, and make sure that they are located in multiple areas in this great state to see those patients who really need them.
Well, thank you for all you're doing. Erica, I had a couple questions. Your 26-year-old patient, were there any other risk factors that you didn't talk about? I'm just thinking about, even though you talked about medications that are mouth drying, I was thinking about like methamphetamine or ecstasy, like all the drugs that are.
Yeah, so she has she does smoke tobacco, but she doesn't use any other illicit substances. She does have a vasculitic, like a chronic vasculitic disease, which they think may have potentially impacted her development of this empyema, but not. But honestly, it's actually quite quiescent at this point, and not on any medications. So besides tobacco use and having grown up in a low-income family in Maine, she didn't have a lot of other sort of risk factors.
And then I just wanted to highlight what Dr. Hoffman said in the chat. Some of it was informational. It wasn't entirely a question, just to remind us all that some well water does contain fluoride, so that you can test the well water to see what's in it. And then he was asking specifically about bringing in hygienists and what percentage of pediatric practices are able to do that. I don't know, Erica, if you have, or Norma, if either of you have any like numbers on that?
I do not. No, that wasn't. I didn't specifically look at that together with this.
Yeah, no, not yet. That's not really a format that is, as far as I know, that's very well embedded in the programs. Although I would like to see it, but I haven't seen it yet too much. I don't know. I'm not aware of it.
Seems like something that even if it got started would be kind of at risk and dependent on the hygienist, like not moving or not, you know, there'd be a lot of places where it could fall through. But that it is a great idea, and in schools as well. Let's see. I see one new message. Let me see. So yeah. So there's some messages to you about joining Operation Smile. And then Dr. Hoffman mentions that a dental hygienist in Waterville Peds for years with great effect, and wasn't terribly, it looks like didn't cost anything. I bet that was a special person too. So thank you all. I don't know if anyone else has any questions that we want to talk to anyone about or exchange ideas before we adjourn for the evening. This was, Erica, I gotta say, it was fantastic the first time you gave the talk, and it's even better this time. It was, your speaking style is outstanding. The information is extremely compelling. You seem to have a passion for it. And I think all of us who are thinking about your going into primary care would encourage you to keep this as an interest of yours. And I think you could probably make a big difference in the state around this issue if you're interested.
Thank you. I appreciate you guys letting me talk about it today.
Yeah, it was really great. So thank you so much. And I just want to remind everyone, I can't remember the topic, but we're doing this again on Thursday night.
Vaping.
Oh, vaping. Oh my gosh, right. This is Devin.
What?
Thank you. I don't, can I just say something about that? Let me get out my phone, because there is a great new podcast. I don't know if anybody's listening to, called I think it's called The Vaping Fix, and it's on Wondery. And I'm in the middle of the first episode. It's only 6. They're not all out yet, but it is really interesting to hear about how this all got started at Stanford and the design school. And so I don't know if anyone's interested in that, but might be something to think about if you're exercising or driving or whatever, to take a look at that. Thanks for the reminder, Annie.
Of course, Jen, I hadn't heard about it. I did know about Stanford's involvement from the early start, but I will have to check that out.
Yeah.
And Dr. Hidu, I just absolutely echo Dr. Jewell's feedback to you. This is just tremendous, and I agree that you will be a natural advocate to continue to use your voice and just your skill to advocate for all of your patients, young and old, on this issue. One question I had, did you come across anything with inhaled corticosteroids and dental caries or decay? And I don't know if Norma wants to weigh in too about it, but it's something I get asked about a lot, and I felt like my training was so limited in dental care. I don't know how to address it.
That's a really good question. I do not know the answer to that, but I will take a look into it and send you what I find out.
You know the answer to that, Norma, about inhaled? So Dr. Coates is a pediatric pulmonologist, so she uses a lot of controller medications for asthma and other pulmonary disease. So do you know if they cause?
So what I've seen, I will only speak for myself, but what I've seen more of with that is like candida infections in the soft palate and in the mouth. But certainly anything that dries the oral environment, that dries it excessively, or sometimes it's not even excessively so that the patient feels it. They don't necessarily know they have dry mouth. It will change the, the pH, and then the patient can be more susceptible to decay, yes.
Is there any chance
Thank
that
you.
oral steroids could make less cavities because you're not having, would it, maybe, well, I guess it's not the inflammation, it's actually the bacteria. So maybe that's why Annie was thinking it would have more cavities than, or more dental disease than patients not exposed to steroids. That's an
Yeah, I
interesting.
mean,
I'm not sure.
we always give them anticipatory guidance on the risk of candidal infections, but I can't tell you, I've had scores of patients come back and tell me their dentists have told them they have increased caries risk because of the inhaled corticosteroids or even discoloration.
Hmm.
And that's just not something I've seen a lot of literature on. So I just was wondering in part what the mechanism was and how we can help try and prevent that when possible, if possible.
Yeah,
Well,
sorry, I don't have a lot more on that.
thank you, everybody, for joining tonight. And if you're available on Thursday, I think it's Deb and Emily Jacobs who are talking about vaping. Annie, are you talking too, or is it just Deb and Emily?
No, it's those two wonderful speakers, but I'll be on and happy to address any questions. that
Great.
may arise. Yeah.
Sounds good. Well, thank you, everybody, for being here tonight. And we will hopefully see a number of you on Thursday.
Thank you.
Great job.